So hi everyone, my name's Bilal Hafiz. I'm a third year medical student at the University of Melbourne. It's my pleasure to welcome everyone to the Pearls Lecture Series of 2023. Before we get started and I introduce our speaker for today, who we're super excited to have, I wanted to quickly talk about Pearls as an organization, and we are joined here by Joe McCann, who can take some questions about Pearls after as well. So Pearls stands for Focus for Emergency and Acute Care in Resource-Limited Settings. So last year in August, the inaugural Pearls course was run in Port Vila in Vanuatu, where doctors received handheld ultrasound probes to plug into their smartphones as well as tablets, and they undertook days of ultrasound training from a visiting team of Australian physicians and other experts, including Dr. John O'Henry, who is the lead of the Pearls program. So after the course, these upskilled physicians had the opportunity to continue receiving really good feedback via remote imaging techniques. And since then, the Pearls Lecture Series was put into play so that we can continue on focusing our support for doctors in these resource-limited settings in their emergency as well as acute healthcare provisions. So today we'll kickstart our lecture series, the Pearls Lecture Series of 2023, with our first lecture being on the upper airway ultrasound that's given to us by Dr. Temesgen Beyene. So a little bit about Dr. Beyene. He's an assistant professor of emergency medicine and critical care at the Addis Ababa University, as well as the head of department for emergency medicine at the College of Health Sciences in Tikkur Enebessa Specialized Hospital, or TASH. He completed an ultrasound fellowship with honors from the Ultrasound Leadership Academy and is involved in focused educational initiatives in developing countries. Dr. Beyene is also a clinical research graduate from the Harvard Medical School with a focus on clinical trials. He's also the current POCUS lead at his department and the recipient of Developing Countries POCUS Education Scholar 2020 from the EMUC Society, or the Emergency Medicine Ultrasound Group of Australia. Currently, Dr. Beyene is also pursuing his MPH at the Addis Constitutional Institute of Public Health. Dr. Beyene, welcome. We're really fortunate to have you today and giving this talk to all of us today here. Before we get started with your lecture, perhaps I was wondering if you could shed some light on your journey within ultrasound and how you put ultrasound into your clinical practice as an emergency physician.
Okay, thank you, Bilal, for the warm introduction, and I'm so excited to meet you all with this virtual lecture series. Can you hear me?
Yep.
Okay, great. You did all the introductions, but to say just few words as far as my journey in emergency ultrasound is concerned. We do have this collaboration with the University of Toronto almost for more than a decade, and then the faculties who come to Ethiopia, Addis Ababa University, through our collaboration, and we were getting the teaching and all the portable scanning techniques were quite exciting by then. While we were doing our very first focused assessment with sonography in trauma and so on. So with that, the excitement kept on, and subsequently I got opportunities with the ULA, Ultrasound Leadership Academy. I get a training because they also sponsor the ultrasound and the SonoSIM simulator for our subsequent training. So all that helped me to further in meeting my colleagues and peers from different places. So with that, I was fortunate enough to find out the Emergency Medicine Ultrasound Group's scholarship, which is meant for developing countries' focus educator scholars. And then I was successful before COVID, and I received the opportunity to travel to Australia. But unfortunately, as we all know, then COVID came and travel restrictions and everything was in place. And because of that, that travel was not successful by the time, but I was fortunate enough to reinitiate that. And I was in Australia just last October, getting the advanced emergency medicine ultrasound training for 5 days and subsequently attending the first ever focus conference that was in person, hands-on, and so everything was quite fascinating from that. So while I'm just doing my EMATs and also attending the conference, I was reading about the Pearls initiative, and then I reached out to some of the colleagues. And by the time when I received email from Dr. Jonathan, it was quite exciting for me to get involved with your initiative. And in short, that's my journey in the world of point of care ultrasound, still evolving.
That's awesome. That's awesome. That's so great to hear. We really appreciate you taking the time today as well and joining us, especially after having such a busy month in your clinical practice. So what I'll do is I'll ask everyone if they could please keep their microphones on mute and save questions for after the talk. That would be awesome. And you can also field some questions in the chat and we can discuss them later. And Joe McCann, who's joined us as well, can take some of your questions in the chat as well. Well, Dr. Beyene, we're looking forward to learning lots from you today. So whenever you're ready, please take it away.
Okay, can I start?
Yep, go ahead.
Okay, thank you, Bilal. And again, it's a kind of good morning from Addis Ababa, from east part of Africa, from here. And probably the time is quite different at your side, as I have seen it from my October visit. So, and I was hearing the weather change, and even it's raining there, but here it's sunny and there is no rain over these few months. So let's start our talk. So our today's talk is, as we have discussed during the planning phase, it's the upper airway ultrasound. It's not as such much detail, but some of the practical aspects, and this is a similar format which I have shared to my Ethiopian Society of Emergency Professionals here on a workshop format and so on. But as our patient population is not as such with a difficult airway as far as surgical airways are concerned, we may not repeatedly use it, but this is quite an important area at times whenever there are difficulties to figure out some of the clinical aspects which we will see on my slides subsequently. I don't have anything to declare for this talk apart from its workshop formats and trainings which are somehow hands-on and on the models for our setup. We start with an introduction. As far as airway ultrasound is concerned, I can just bring you one of the important talks from the American Society of Anesthesiologists, the difficult airway algorithm. On that, there are these scenarios, the can't intubate and then the can't ventilate scenarios. By then, we will end up doing cricotiotomy or tracheotomy, obviously. So while we are attempting to go with the rapid sequence intubation, that's obviously something which we do repeatedly at the busy emergency centers and in trauma setups and scenarios like that. But here, the can't intubate, can't ventilate scenario is quite difficult because we may not end up salvaging the patient. So for that, the cricothyrotomy and tracheostomy, these are the best options. Even in that case, to do the cricothyrotomy or tracheostomy, it may not be as such easy. So there are some literature findings and publications, but still much is lacking as far as emergency surgical airway practices are concerned, at least about the utilization of point of care ultrasound. Otherwise, we are using it for our trauma management as well as resuscitation of patients on its focus assessment with sonography in trauma and even EFAST formats and so on. But nowadays, there are increasing moves as far as using ultrasound in the upper airway management is concerned. So that's what inspired me and what stimulated me to go over this talk as well as over this area of expertise. As we all know, surgical cricothyrotomy is performed with simple steps. As we see it here, one person even can do it just by putting our non-dominant hand, securing the trachea, and identifying our landmarks without even using the ultrasound. Obviously, we can make a fast longitudinal midline incision over the thyroid and cricoid cartilage where the cricothyroid membrane is located, and subsequently with the transverse stab, and we can get a membrane, and it's all about putting our number 6 millimeter tube and then inflating the cuff and securing it, and then with that, we can simply salvage such a difficult scenario. So this is how the steps are concerned. So to do with those simple steps, it always requires a landmark technique. So the landmarking is, we can start from our sternal notch, we can palpate superiorly until we can reach into the laryngeal prominence. As we all know, the thyroid cartilage is the largest one, and then we can identify the cricothyroid membrane in between, approximately just like one finger breadth below the anatomical side. If it's not palpable with this method and so on, we can at least place our 4 fingers, just like how we assess the difficult airway. and we can put our fifth finger, and that's just near the site of cricothyroid membrane. So after locating the site, we'll proceed with the procedure, either with the open technique or with the needle cricothyrotomy technique as far as intervening in such scenarios is concerned. So there is also an alternative four-step technique, fastly identifying the landmark earlier than making the 1 to 2 centimeter horizontal stab incision rather than the vertical one through both the skin and cricothyroid membrane. This is all about time buying. And before we remove our scalpel, obviously we can insert a tracheal hook and directly we can proceed with it and inserting the tracheostomy tube through the incision to the trachea. What we are doing is a time-sensitive issue to save the patient, and later on, revision for the formal tracheostomy can be handled by our ENT physicians, other specialty teams, and so on. So what we are doing is all about the life-saving at the earliest point in time. So this is just the summary of the anatomical size with the landmarking techniques. As you see this at the middle picture, the vertical line is the incision site. We do have the thyroid cartilage is the largest superiorly. Then we do have the cricoid cartilage, and in between is the cricothyroid membrane, which we exactly see on the third picture. The issue is it may not be as such easy with the landmark techniques to go with the exact site of the incision and so on. So when we say a few words about the point of care ultrasound in airway management, it's a rapid and affordable and portable tool as we all know it, and it's very dynamic modality for evaluation of this anatomy, especially in those patients with a difficult airway, probably the short neck, those patients who are obese enough and so on. So it helps us in facilitating the endotracheal intubation when it's performed by trained clinicians. Trained clinicians, I mean, emergency physicians can do it, anesthesiologists can do it, whoever is trained on this can perform the procedure. So the sonographic assessment of the airway may be performed either before such interventions are in place or during the intervention itself or even after securing the airway and so on. So these are one of the areas we want to focus. So when we do the point of care ultrasound evaluation of airway, two things come into picture, two important things. That the first one is preparing potential surgical airway as a preparation. And the second one is the confirmation of the tracheal tube placement. And that's more of indirect confirmation because what we are doing is whether the tube is going into the esophagus or not. We don't usually confirm ET tube passing into the trachea with ultrasound for obvious anatomical differences and difficulties, which I will be touching later on in my slides. So upon the identification of a predicted difficulty of the airway, the clinicians, as I said, locate, and we will subsequently end up marking the cricothyroid membrane before our attempts for the non-surgical airway management are in place. So during this preparation phase, the utilization of POCUS will help us in facilitating the placement of the emergency cricothyrotomy just by helping in identification of the site in quite a simple way, just by placing our linear probe in a vertical format in the longitudinal marking technique. So when it's difficult to identify the landmarks with the inspection or with a palpation, this utilization is quite beneficial. Again, this is the anatomical picture. You can clearly see the thyroid cartilage, the biggest one. Then we do have the cricoid cartilage and the area or the spaces in between. So when we say the confirmation of the ET tube placement as a second aspect, what we are doing is a confirmation of the tracheal tube placement, which is performed indirectly, because what we are looking for is if the ET tube is mistakenly going into the esophagus. Even before bringing our ultrasound probe, we may sense that our intubation is difficult, possibility of esophageal intubation is there, so we may be in that controversy and we may even end up just removing or replacing the tube. As we all know, trachea is such a cartilaginous structure, so because of that nature as well as because it's in our breathing system from our physiology and the anatomy itself, air-filled structure, so that may make it a bit difficult to look in the ultrasound. So we may end up in looking the ET tube in the esophagus rather. So recognition of the ET tube as it passes to the left and to the posterolateral aspect, that is to the trachea, is indicative of the esophageal intubation. So if the tube is not visualized in the esophagus, and if we are also getting the condensation, the usual condensation, which we confirm from the right tracheal intubation, we can correctly and we can safely say that it's the tube is in the trachea. So more of utilization of point of care ultrasound in ET tube placement is a kind of indirect confirmation. That's the guidelines and the documents also state. So when we look for the focus in airway, the relevant tissues which are visualized at the time of placing our ultrasound probe, that's quite important aspect, because we do have the cartilage, the thyroid cartilage, the cricoid cartilage is there, and the tracheal rings are there, and there is also this interesting and quite fine line interface of the trachea, mucosa, and the air within it. So that's what we call air mucosal interface. So the esophagus, thyroid gland, and the common carotid arteries represent the surrounding structures, which are relevant anatomical structures indeed. So identifying all these structures is quite important. As we all know, cartilages have this what we call hypoechoic or dark nature, as it's a term on our sonographic identification. And there is a significant difference in the acoustic impedance between the soft tissue and the air. So because of that nature, sound waves are passing, but they are at the same time strongly reflected, resulting in a hyperechoic or what we call a bright appearance at the air mucosal interface itself, the AM interface. And hyperechoic thin line just deep to the tracheal rings, the cricoid cartilage and the thyroid cartilage, as we see it on the next slide, is the picture. So the air within the tracheal lumen doesn't permit the transmission and the return of an ultrasound beam, and the lumen and the posterior wall are therefore not as such visualized. This is a typical picture format as you see. Here, you can look into all the structure, the thyroid cartilage, the biggest one, then the cricoid cartilage is here, then there is this thin line, which is hyperechoic in between. That's exactly where the leukothyoid membrane is located. Apart from that, you can see the rings here, the typical ring patterns, which what we call as a string of pearls appearance. It's because of the interface nature. On the picture underneath as well, we can clearly look into the leukothyoid membrane. Subsequently, we can get the tracheal cartilage. We can start it either caudal or from the cephalad direction. So what helps us is these anatomical features and the echogenicity and its findings from different problems. So the air mucosal interface is quite reflective, and it's a very characteristic pattern, which helps us in identifying the site as well as to reach into the picture itself. And there may be a similar appearance to the A lines, which we can see from our lung ultrasound when we do the lung focus and so on. Thyroid gland, it has the characteristics of this, the homogeneous ecotexture, and it's identified both laterally as its main lobes are located, or at times anteriorly from its isthmus aspect. Again, here it's the another picture to look into the esophagus as well as the trachea. It's a transverse view, as we clearly see. You can see the carotid artery from this side. You can see the air-filled lumen of the trachea, and then at the same time, you can also look into the esophagus. So when we look into the ET tube passage into the esophagus, it's quite easier to look into that because the trachea, as we say, is an air-filled lumen, and the cartilage and the air mucosal interfaces can affect the visualization of the tube itself. So the other point is our transducer selection. You have heard that I was repeatedly saying the linear probe. So the anatomical structures of interest are quite superficial enough. So that's the main factor that we are using the, the linear probe with the high frequency, and it's best evaluated with that, and it's the best chosen format. So it has a smaller transducer footprints. It has a high frequency. When it's compared with the curvilinear transducers. So the curvature and all those things, the linear nature of this probe helps us to utilize it in looking the exact anatomical sites. But otherwise, some of the deeper structures in the airway can still need utilization of curvilinear probe. If we want to look into the tongue or pharynx and also the lungs, that can still be performed with the low frequency curvilinear probe. So what about the image optimization and the exact identification of the pyromembrane cell? We have to adjust our depths, the gain, and we have to select the focal zones, which should be set appropriately so that we can look exactly into the membrane itself. We may reduce the excessive depths, and at times we may need somehow deep enough based on the individualized nature of the patient groups. And subsequently, we will end up identifying the cricothyroid membrane when the patient's neck is in a full extension. But we have to be very careful if we are dealing with someone who sustained a trauma or where we are also anticipating a possible cervical spine injury or so. So we apply the linear transducer to the caudal line of the anterior neck with a directional indicator oriented toward the patient's head. So that's exactly how we can pick the exact site. We can start from the notch or we can start from higher up. So this is how the probes are placed. As you can see, it's a linear probe. The indicator is towards the patient's head and it's exactly placed vertically. So this is what we call the appropriate placement on the longitudinal view to look for the cricothyroid membrane. So the tracheal rings are visualized as a series, or as we say, the beads of ring, or what we call, and they end up terminating. So by the time when we start from the notch and if the rings are disappearing, we are just exactly getting the cricothyroid membrane itself. So as we have seen on the previous pictures, we may try to adjust the image optimization techniques and we can get the hyperechoic line deep to the string of beads, which represents the air mucosal interface, and subsequently the transducer is moved more cephalad, and then the cricothyroid membrane is exactly identified. So the membrane itself may not be as such clearly visualized. It's not like the air mucosal interface or the tracheal rings. So we have to be very careful in our probe movements. We can adjust the depths, and obviously we can put a surgical marking pin once we get the exact place from our ultrasound visualization. This is how we can get the trachea. You can see the mucosal interface line beneath, and then exactly the membrane itself. Here, it's just
starting here,
a video.
You can see the tracheal rings as individual hypoechoic structures. There's one, another. Just above the air mucosal interface. The air mucosal interface you'll see is a bright line where air is reflecting the ultrasound waves back. You'll see reverberation artifacts similar to A-lines lung deep to that. So these are tracheal rings. As we come cephalad with the transducer, the first large hypoechoic structure that we see, chronological structure, that looks different from the tracheal rings is the cricoid structure. And as we continue to come up, we'll see another one above it, which in this case is thyroid. And this gap in the cartilages in the air mucosal membrane is the cricothyroid. And this is where you would place them. You center that on the screen and place a mark with the surgical marking pen and be able to localize the appropriate cephalad caudad level at which the membrane is located. You could also locate midline in a patient's non-palpable landmark and place a mark along the midline this way. And at the point where those marks intersect,
So this is exactly a nice summary video by Dr. Mike Stone, one of the founders of the Ultrasound Leadership Academy. They do all these quite interesting practical lectures as well as demos. So the second part is the endotracheal intubation. So as I have repeatedly said, this is more of an indirect technique because what we are looking into is not directly visualizing our ET tube passing into the trachea. Rather, if we are just mistakenly putting the tube itself on the esophagus and so on. So we can clearly identify that, and we can rightly say it's on the esophagus or. So here is one of the visualizations. Still, we can use a transducer, which is linear enough. We can place it more on the transverse format, and subsequently we can get the identification. And probably this is a better picture. You can look into the trachea, and you can see the esophagus here with its clean layers, which are quite easily separated, and the carotid artery is just need to. So as a different operator advances here, it's not something that only one person can do in terms of identifying the membrane and also using the probe. Rather, while someone is doing the exact intubation, another operator who is trained enough tries to look with the ultrasound. So as the ET tube passes, we try to look into the esophagus, and as far as the ET tube is not going to the esophagus, we can say this is the right tracheal intubation. And absence of these signs indirectly confirms the placement of the tube. This is a video demonstration again.
So this is a video of South patient of the trachea with the shadow. Over here, we're able to visualize the broad and esophagus, although not clearly seen in it, and the left. And this is the expected location of the esophagus. So as this takes place, you'll see the hyperechoic tube appear adjacent to the trachea. Here in the esophagus, we're seeing another hyperechoic curve with shadowing. This is a tube inadvertently or unintentionally inserted into the esophagus, and adjacent to it, we're still able to see the trachea. When an esophageal inflammation is recognized as a distance, the tube can be removed prior to installation. In this case, and a second. This is a case of a successful tracheal. Here we're going to see the curve right with shadow and right over across the distance. Yes. Second as is reported by this past break, in this case, we're not seeing evidence, but indirect absence of esophageal signal, we're able to further successful. In another case,
so the other point is whenever we do the right tracheal intubation, and if the ultrasound is placed in the transverse format of the linear transducer, we will not be getting the posterior shadowing whenever the intubation is right in the trachea. We will not get the posterior shadowing in the esophagus. So that's one of the tips for indirect confirmation. So some few final points. As we all know, real-time imaging with a continuous observation and during our tube advancements optimizes the application of the ultrasound for our airway management. It's a tool which aids, which helps us in terms of using our time effectively. It helps us whenever it's used accurately, it helps us to confirm the right placement of the tube in the trachea. And with this technique, as well as with the other added traditional methods of confirming ET tube placements, be it with the capnography, auscultation, or direct visualization of the condensation in the air itself, it will help us in confirming the placement of trachea, and it helps in potentially decreasing the risks for making our valve masks really to trouble the stomach and so on. And also subsequent aspirations can be minimized. So these are the references for my talk. This is all I have. Thank you.
Great, awesome. Thank you so much for your presentation, Dr. Beyene. Do we have any questions for Dr. Beyene? Dr. Beyene, you can turn your camera on now if you'd like. Do we have any questions, perhaps about the videos? Anything else?
Oh, I just saw from the chat that from the videos, I think the audio was not possible.
Perhaps the videos that you showed in the last little while, the two recordings of the videos, perhaps you could talk over them. I think the audio was a little poor on those videos. Perhaps you could just go back and just you can just talk over the findings of those videos if you can.
Perfect. Yeah.
Great.
Because I just made it on a full screen view, I haven't noticed about the comments on the chat box.
Oh, that's all right. That's okay.
So here is the first video.
Starting
As
here,
we have said,
we can see
the
the
transducer
rings
placement, the linear
and
probe is placed
individual
vertically,
echoic structures.
and
There's
while the
one,
movement is
another,
there, we can get
another.
very smaller
Just above
hypoechoic
the
structures
air mucosal interface.
above the
Air
air
mucosal interface,
mucosal
you'll see is a bright
interface.
line
But the
with
air
arrows
mucosal
reflecting
interface is a
just
straight
underneath that.
hyperechoic
You'll see
line
reverberation
here.
artifacts similar to
And
A
below
lines
that,
in the lung,
there are
deep in the back.
similarities
So
with
these
the
are
A lines
tracheal
of our
wings.
lung
As we come
scan.
cephalad,
Subsequently, when we go cephalad,
large
we can
tracheal-
get a
first
larger
large,
structure.
hypoechoic
The first
structure you'll
larger
see, cardiac
hypoechoic structure is
that looks
the
different from the tracheal wings
thyroid
is the
cartilage.
cricoid.
And then
As we continue to
subsequently,
come
when
up,
we move higher up,
we'll see another
we
one
can get
above it, which in this case
another
is the
bigger
thyroid.
structure. I mean, this
this
one here,
gap
cricoid,
cartilage
thyroid.
in the air mucosal
And then in
membrane
between is
is
the cricothyroid membrane. Look,
and this is where
it's
you
a bit
place
difficult
some of
to
that on the
bring
screen,
exactly
and
the
place the mark
cricothyroid
of
membrane
the
itself.
and
Rather than that,
and
bringing the
look
air
at
mucosal interface is a bit easier.
appropriate cephalad
The superior to
level
it, in between the two
membrane is
cartilage,
located.
is
You
the
can also
air,
locate
I mean
midline
the cricothyroid membrane.
non-palpable landmark and place a mark along the midline of this way.
I think it's clear about this video now.
Right, I think it's a bit more clear now for sure. Thank you for that clarification. And just, I think the very last video that you had also presented here would be it would be good, beneficial for us to just go over that with your voiceover on it as well.
Perfect, perfect. So here,
So this is
again, the linear transducer is placed transverse, and this is actually a wrong esophageal intubation. So as we see, trachea is here, and subsequently you can see the carotid artery, and esophagus is a bit not clear. It's around here, and it's quite deep enough. But with the recorded format in a dynamic, I mean the video format, the movement of the tube with the posterior shadowing is something we are going to observe here. Look, the trachea,
here, adjacent to
and then the esophagus.
see another
What we are getting is there is a hypoechoic curved line with posterior shadowing. So the posterior shadowing is created because of the tube, which is wrongly placed in the esophagus. In normal circumstances, this shadowing is expected in the trachea. On the third video, that's what we are going to look into. So here, it's wrongly in the esophagus because there is a hypoechoic tube with posterior shadowing, which is created because of the tube in the esophagus. So this video, the final one,
This is a case of
look, the trachea is quite visible with carviness of the hyperechoic line, and then the posterior shadowing, which was exactly similar pattern in the esophagus on video 2. Here we get the lobes of the thyroid, and subsequently you can get esophagus here. But esophagus is quite different here because there is no any posterior shadowing, just like in video 2. So just by utilizing our other clinical tools of visualization of the tube passing the vocal cords, and also condensation or even capnography and so on, we can safely say that the tube is in the trachea. It's not in the esophagus. So this way of indirect confirmation of placement of the tube in the trachea, just by confirming absence in the esophagus, is one of the tools where the point of care ultrasound utilization is in effect in the upper airway ultrasound. Thank you.